Here we present a case series looking at cavitating lung lesions in patients with COVID-19 pneumonia. COVID-19 is an infectious disease caused by severe acute respiratory coronavirus 2, SARS-CoV-2, and was declared a worldwide pandemic on March 11, 2020. It is primarily a respiratory pathogen and has been shown to infect human respiratory epithelial cells through interaction between viral proteins and the angiotensin-converting enzyme 2 receptor. This receptor is also present on the surface of vascular endothelial cells located in the heart, kidneys, liver, and other tissues. However, since COVID-19 was first described in 2019, numerous reports have highlighted that multiple other organs have been negatively affected. Whether complete remission following the initial acute phase of SARS-CoV-2 is possible remains largely unknown, and a clear clinical picture of the aftermath has yet to be elucidated. Typical radiological findings seen on CT thorax of patients with COVID-19 pneumonia are well described and most commonly include ground glass opacities and consolidation. Our case series includes 5 patients who were admitted to our ICU with COVID-19 pneumonia and who developed pulmonary cavitation. At admission, all had the expected radiological findings and no evidence of cavitating disease. All required intubation and positive pressure ventilation. The median time to intubation from symptom onset was 9 days. All patients were treated with steroids and 1 received tocilizumab. The median time to radiological diagnosis of the cavitating lesions was 28 days. 3 of the patients died in ICU from complications of COVID-19. Pulmonary cavities are abnormal, thick-walled, gas-filled spaces within the lung parenchyma. Cavitating lesions are usually associated with fungal, mycobacterial, autoimmune, or neoplastic processes. They form in areas of dense consolidation which evolve into necrosis and cavitation. They are not routinely associated with viral pneumonia. Cavitating lesions associated with COVID-19 pneumonia are considered rare, and the exact mechanism leading to their formation is unknown. Possible mechanisms proposed in the literature include superimposed or opportunistic infection due to tissue infarction, or may be part of the natural history of severe disease. All 5 of our patients had positive microbiology as shown in the table, and it is possible that superimposed fungal or bacterial infection may have contributed to cavity formation. Opportunistic infection in immunosuppressed patients is another proposed mechanism. While steroids have been shown to have a survival benefit in COVID-19 disease, they are known to suppress the immune system. All patients in the series received steroid therapy and 1 received tocilizumab. The literature describes cases where no secondary infectious agent was identified. In our patients, and in cases described in the literature, cavitating lesions develop later in the course of the disease and may be part of the natural history of severe disease, representing a more severe pulmonary complication associated with a higher viral load and longer duration of infection. To conclude, this series describes a significant yet rare complication of COVID-19 pneumonia. The literature is thus far limited to case reports, and this is considered a rare event. The exact mechanism remains unclear and is likely multifactorial. The possibility of such complications should be considered in all patients with severe disease. Secondary infections should be identified and treated. Further studies are needed to investigate a possible association between iatrogenic immunosuppression and lung cavitation in the setting of COVID-19 disease.